Ascites. Ascites is a free fluid in the peritoneal cavity. It may be the result of local inflammation or venous obstruction or be part of generalized edema. Pathophysiology. The mechanisms responsible for the development of ascites are not completely understood. Portal hypertension and the resulting increase in capillary pressure and obstruction of venous blood flow through the damaged liver are contributing factors. The failure of the liver to metabolize aldosterone increases sodium and water retention by the kidney. Sodium and water retention increased intravascular fluid volume and decreased synthesis of albumin by the damaged liver cell contribute to fluid moving from the vascular system into the peritoneal space. Loss of fluid into the peritoneal space causes further sodium and water retention by the kidney in an effort to maintain the vascular fluid volume, and the process becomes self perpetuating. As a result of liver damage, large amounts of albumin rich fluid, 15 liter or more, may accumulate in the peritoneal cavity as ascites. With the movement of albumin from the serum to the peritoneal cavity, the osmotic pressure of the serum decreases. This, combined with increased portal pressure, results in movement of fluid into the peritoneal cavity. Clinical manifestations: increased abdominal girth and rapid weight gain are more common presenting symptoms of ascites. The patient may be short of breath and uncomfortable from enlarged abdomen, and striae and distended veins may be visible over the abdominal wall. Fluid and electrolyte imbalances are common. Assessment and diagnostic evaluation: the presence of extent of ascites are assessed by percussion of the abdomen. When fluid has accumulated in the peritoneal cavity, the flanks bulge when the patient assumes a supine position. The presence of fluid can be confirmed by either percussing for shifting dullness or by directing a fluid wave. A fluid wave is likely to be found only when a large amount of fluid is present. Daily measurement of recording and of abdominal girth and body weight are essential to assess the progression of ascites and its response to treatment. Medical management: first one is dietary modification. The goal of treatment of the patient with ascites is a negative sodium balance to reduce fluid retention. Table salt, salty foods, salted butter and margarine, and other all ordinary canned and frozen foods. Foods that are not specifically prepared for low sodium diets should be avoided. It may take 2 to 3 months for a patient to taste buds to adjust to unsalted foods. In the meantime, the taste of unsalted foods can be improved by using salt substitutes such as lemon juice, oregano, and thyme. Commercial salt substitutes need to be approved by the physician because of those containing ammonia could precipitate hepatic coma. Most salt substitutes contain potassium and should be avoided if the patient has impaired renal function. The patient should make liberal use of powdered low sodium milk and milk products. If fluid accumulation is not controlled with this regime, the daily sodium allowance may be reduced further to 500 mg and diuretics may be administered. Dietary control of ascites via strict sodium restriction is difficult to achieve at home. The likelihood of that patient will follow even 2 gram sodium diet increases if the patient and the person preparing meals understand that rationale for the diet and receive periodic guidance about selecting and preparing appropriate food. Approximately 10% of patients with ascites respond to these measures alone. Non-responders and those who find sodium restriction difficult require diuretic therapy. Second one, diuretics. Use of diuretics along with sodium restriction is successful in 90% of patients with ascites. Spironolactone, aldactone, an aldosterone blocking agent, is most often the first line therapy in patients with ascites from cirrhosis. When used with other diuretics, spironolactone helps prevent potassium loss. Oral diuretics such as furosemide, that is Lasix, may be added but should be used cautiously because with long-term use They may also induce severe sodium depletion, that is hyponatremia. Ammonium chloride and acetazolamide diamox are contraindicated because of possibility of precipitating hepatic coma. Daily weight loss should not exceed 1 to 2 kg in patients with ascites and peripheral edema, or 0.5 to 0.75 kg in patients without edema. Fluid restriction is not attempted unless the serum sodium concentration is very low. Possible complications of diuretic therapy include fluid and electrolyte disturbances including hypovolemia, hypokalemia, hyponatremia, and hypochloremic alkalosis, and encephalopathy. Encephalopathy may be precipitated by dehydration and hypovolemia. Also, when potassium stores are depleted, the amount of ammonia in the systemic circulation increases, which may cause impaired cerebral functioning and encephalopathy. Bed rest. In patients with ascites, an upright posture is associated with activation of the renin-angiotensin-aldosterone system and sympathetic nervous system. This results in reduced renal glomerular filtration and sodium excretion and a decreased response to loop diuretics. Bed rest may be useful therapy, especially for patients whose condition is refractory to diuretics. Paracentesis. Paracentesis is the removal of fluid, ascites fluid, from the peritoneal cavity through a small surgical incision or puncture made through the abdominal wall under sterile conditions. The detailed things given in the shots. So other methods for treatment: insertion of peritoneovenous shunt to redirect ascitic fluid from the peritoneal cavity into the systemic circulation is a treatment of modality for ascites, but this procedure is seldom used because of the high complication rate and high incidence of shunt failure. The shunt is reserved for those who are resistant to diuretic therapy or not candidates for liver transplantation and have abdominal adhesions and are ineligible for the other procedures because of severe medical conditions such as cardiac disease. Thank you.